GUcast Journal Club is supported by our Journal Club partner, MSD.
Well, another month has sped by, and that means it's time for another episode of the GUcast Journal Club. Hello, Declan.
Hello, Renu. How are you?
I'm good, thank you. Kind of battling through a wintry Melbourne.
Yeah, it's terrible, isn't it?
It's terrible for November. We're weeks away from Christmas, and I've got my big jacket today.
But it was like 32 degrees and sunny last week. So, yeah, welcome to Melbourne.
Welcome to Melbourne. Well, hopefully that picks up, but never fear. We've got a Journal Club, another episode of the Journal Club to cheer everyone up. And, you know, I was just thinking, how timely are these Journal Clubs? Because our last episode focused on the ERSPC trial.
Yep.
And just days after we released that, we had the 20-year update?
Yeah, 23-year
update.
So it was prescient. We must have known it was coming.
It was just so timely.
Yeah, we got great feedback because, 23-year update published in New England Journal of Medicine, ERSPC. But for the youngsters out there, they barely know what that is. But if they listen to last month's GUcast,
go back and check it out.
There it was. You can hear me whittering on about,
as well as a PLCO trial. Yeah, it was a very interesting episode there. But don't worry, we've got another couple of great papers to discuss today, and we want to welcome back our two GUcast Journal Club editors. We've got Carlos Delgado in the studio. Carlos, welcome back.
Thanks for having me here, Renu and Declan.
Did you have a busy day at work today? Because, of course, you did have a busy clinical day at Peter Mac.
We did, yeah. But tomorrow we will have you back, Declan, at work.
I know. I've been on long service leave, sort of sabbatical for the last... is it 6 months?
6 months.
From one of my role at Peter Mac. So yeah.
Looks like they missed you.
I know. Yeah, back in the operating theatre there tomorrow.
Wish Declan could say the same, but
but yeah.
And also a huge welcome back to the GUcast Journal Club for our other editor from Munich, Elena Berg. Hello, Elena.
Hello from Munich. Great to be back.
Great to see you. Last time we were talking about Oktoberfest and how you looked a little bit weary after all the festivities, but you look much fresher today. You ready to go?
I've recovered.
Very good. So today we're going to be discussing two papers, and it will be familiar to most of you. One is the PRECISION trial, of course, that was published in 2018. And the other is an interesting one. We're going to branch out to bladder cancer today, and we're going to be discussing the EB-StaR trial, which is the en-bloc bladder tumor resection for non-muscle invasive bladder cancer. Very surgical, very interesting.
Yeah, two cracking papers, and thanks as ever to our GU Journal Club partner, MSD, who've been great supporters of this podcast. So thanks very much to them for supporting it. And yeah, look, as we try and do with Journal Club, like any classic Journal Club, Renu, we try and pick papers that, we as practicing clinicians, but especially probably trainees, need to know a bit about. PRECISION was a landmark trial in 2018, which fundamentally changed our approach to early detection of prostate cancer. And these are really important trials because why do we do so much MRI now for patients with an raised PSA and a suspicion? It's really predominant. If you had to pick one paper, it was the PRECISION paper, and it also led to reimbursement for MRI scanning in many countries, including Australia. So let's learn today a bit about PRECISION and why that matters. And the other trial, again, you kind of called it out, Renu, that maybe not enough people know about this trial. Now, we already covered it on GUcast, didn't we?
We did. We had a special episode with Jeremy Teo. But it's an interesting one. And I love these trials that really challenge the dogma of standard practice.
Yeah.
And makes you think about, well, is this the right thing to do, and can we do anything better? That was a really great episode of GUcast. If you haven't heard it, please do check it out.
Yeah, and stay tuned to this one. And by the end of it, when you're going in to do a TURBT tomorrow morning, you're going to be challenged to wonder, am I doing this the best way possible? Level one evidence about how you should be doing that small bladder tumor. So that's coming up later in the podcast. But first, let's go back to Munich. So Elena, I think you're going to kick off and cover the PRECISION trial. As ever, we're going to put links in the show notes. So top line summary of this trial and strengths and weaknesses, and then we'll have a bit of a discussion.
Yeah, so we have just recently talked about the TRANSLATE trial the other week, comparing biopsy techniques. So I'm happy that today we're going a bit back in time to also talk about probably, as you say, one of the most important trials in the landscape of prostate biopsies when it comes to the use of MRI and MRI-guided biopsies. The PRECISION trial was published in the New England Journal of Medicine in 2018 and conducted in an era where trials evolved around the question of how to sufficiently diagnose clinically significant prostate cancer, while at the same time reduce the overdiagnosis and possible overtreatment of clinically insignificant prostate cancers. It was a prospective multi-center trial at 25 centers in 11 countries. 500 men with a clinical suspicion of prostate cancer, either an elevated PSA less than 20, abnormal DRE, or both, were randomized to receive either multiparametric MRI and MRI targeted biopsy if the MRI was positive, versus no MRI and just standard biopsy. A positive result on MRI was defined as pirates greater than 3, and a maximum of 4 biopsy cores were obtained from each area suggestive of prostate cancer via transrectal or transperineal approach, cognitive or software-assisted biopsies. The standard biopsy was defined as just 10 to 12 cores by transrectal biopsy. It is important to note that patients who received the targeted biopsy did not have additional systematic biopsy, as it might be the standard in many centers and institutions today. The primary endpoint was the proportion of men with clinically significant prostate cancer defined as Gleason score greater than 7A or ISUP grade group 2 or higher. And further endpoints were the proportion of men with clinically insignificant prostate cancer, the proportion of men in the MRI group who did not undergo biopsy, and adverse events. When we talk about the results, clinically significant prostate cancer as the key message was detected in a significantly higher proportion of men, in 38% in the MRI targeted group, compared to just 26% in the systematic or standard biopsy group. The rate of clinically significant prostate cancers was, of course, highest among the PIRATES 5 score patients. It was 83% compared to 60% in PIRATES 4 and 12% in PIRATES 3. And at the same time, of the 252 men in the MRI group, 28% had a negative MRI and therefore did not undergo biopsy. And further, fewer men in the MRI group received the diagnosis of clinically insignificant prostate cancer. It was just 9% versus 22%. The median number of biopsy cores was 4 in the MRI targeted group and 12 in the standard biopsy group, and also the health-related quality of life at 24 hours and 30 days did not differ between both groups, but the participant-reported complications at 30 days were less frequent in the MRI targeted group. So in conclusion, it was shown that in biopsy-naive men, the use of MRI followed by MRI targeted biopsy, if positive, detected more clinically significant cancers, fewer insignificant ones compared to the standard biopsy, with at the same time avoiding biopsies in 28% of men. When we talk about strength and limitations of the trial, a huge strength is, of course, its clinical impact. It was a trial answering a very important question in prostate cancer diagnostics. Can we identify patients who would need treatment for their cancer, at the same time have less overdetection of clinically insignificant prostate cancer, and reduce unnecessary biopsies? It was a large, multi-center, international design with a clear clinical pathway, and it had a high adherence to the protocol and had a favorable short-term side effect profile observed in the MRI targeted group. Limitations might be that various biopsy techniques were allowed, both transrectal and transperineal, and both visual registration and software-based registration. There still was the potential for missed clinically significant cancers in the MRI group. We know from other trials that a small proportion of clinically significant cancers may be missed when systematic biopsy is omitted, up to 15%. And there was variability in MRI interpretation, differences in MRI protocols and reader expertise, and experience with MRI targeted biopsies, which on the other hand might be a strength as well because it reflects real world conditions. So overall, a well-designed trial with great clinical impact showing superiority of the MRI pathway.
Awesome. What
Beautiful
a summary.
Yeah. Wow.
Yeah, you've totally nailed it. And that's why it was so important. It was actually, your last point, it was quite pragmatic, wasn't it? And they also had a mixture of 1.5 and 3 Tesla magnets as well. And yeah, what was the concordance between MR radiologists? It was about 0.8 or 0.75 or something.
78%. The radiologist, the accordance was 78%, and the pathologist, I think, 88%.
Yeah. So look, these are acceptable limitations in real world practice, and that's why it was such an overwhelmingly well-received trial. And I suppose we should shout out to first author Viru Kazi, a great friend of the podcast, did a fellowship with us.
That's right.
And senior author Caroline Moore, another great friend of the podcast, big New England Journal publication. And I remember, Renu, because I did the discussion on that when it was presented at the EAU. Can't remember which country, but it was a simultaneous publication in New England Journal of Medicine, and I got to do the discussion while Viru presented it, like he was a fourth-year registrar, first New England Journal paper.
Yeah, landmark study, isn't it? And it really, I mean, when was the last time you've done a biopsy without an MRI?
Yeah, exactly. It almost never happens, and it's literally only the men who can't have one for some reason, you know.
Exactly, and then we'd probably get a PET scan, wouldn't we?
Yeah, exactly.
But yeah, no, it has become the standard of care against which all new, technologies are pinned against, and we're looking to see if we can further improve and streamline the detection of clinically significant disease with things like PSMA PET CT.
Yeah, and actually the primary 2 trial that we've just finished accruing, 650 patient study, is kind of based on the design of PRECISION. It's almost, and it's a follow-on from it, and we'll be presenting that data at the EAU next year. So we don't know is it positive or negative, but again, it was inspired by PRECISION, and it was to deal with what you do with the normal MRI scans. So here in Australia, as I said, Elena, this led to within 6 months reimbursement of MRI, because we said to the government here, it will lead to the 3 things really. One is better detection of clinically significant cancer. Number 2, less men undergoing a biopsy, because we said we will believe it. You know, if the MRI is negative and there's no red flag, we're going to say you don't need a biopsy, and that's true today. And third, really importantly, dropping the overdiagnosis of insignificant cancer. One of the most important things, which I highlighted, I remember in my discussion, dropping that from, was it 23% down to 9%. So that's 23% of men in the standard arm will be diagnosed with low-grade cancer. And if you follow an MRI pathway, that drops to less than 10%. You know, so it deals with one of the key limitations of early detection strategies is still overdiagnosis. So MRI deals with that if you follow an MRI pathway. But it's not the same all around the world. So, for example, in the US, it's still not normal for everyone to get an MR in the setting of, suspected prostate cancer. It's only in certain institutions, or there can be costs, or they have to have had a negative trust biopsy first. So it's hard to get the exact number, but I think it is across the whole of the US, across all practice, a minority of patients. What's the situation like in Germany?
In Germany, everyone gets their MRI before biopsy, but still it's not reimbursed for everyone yet. Only if you do it at university hospitals, but hopefully that's going to come in the future. We hope that it will be reimbursed sometime soon for everyone.
Yeah, interesting, isn't it? I mean, we're lucky here in Australia that it is reimbursed, but we have had these discussions before. Declan, is the threshold of PSA for which we do an MRI adequate enough, and should we be changing that to be lower? Even will it miss significant cancers? And I guess primary 2 will help answer some of those questions by using another modality of imaging. But I guess those sorts of dilemmas will always exist.
And the other thing that criticism that sometimes comes out of it is, it's underpinned, this whole MRI in early detection is underpinned by having high quality MRI, isn't it? That's always been the discussion. And people say, depends on, who's reading it and is it a high field strength magnet, etc. But the only way you kind of deal with that is just go with it. And you create a high volume MRI environment by bringing in reimbursement. And then guess what? It's not exotic. Everyone's doing it. We get fast readouts. AI will probably smooth out a lot of the inter-observer variability anyway. And most recently, the PRIME study, which again from Viru Kazi and team, showed that we can just do biparametric MRI. We don't have to do the multi-parametric that was done in PRECISION. So that reduced costs, reduced time, so
increases accessibility.
Exactly.
Yeah.
The argument for MR in early detection has never been stronger. I think.
And if there's been one thing, at least for us in Australia and many parts of the world, that's really reduced over detection of insignificant disease, it would be that.
And Carlos, so what's the situation in Mexico? Is MR used in early detection?
So it is, but it's mostly paid out of pocket for patients. So most of the patients that have MRI, they have it only until they had a negative biopsy and high suspicious of prostate cancer after a negative biopsy.
A previous negative biopsy. Okay, but it's moving, I think, in that direction, isn't it? And finishing on that, last year we wrote this. We were involved in this commission, the Lancet Commission on Prostate Cancer. So Lancet do these great commissions. They've just done one on cancer care. I've just seen, haven't read it yet. But we were involved in this 2-year process as commissioners, and we published this whole report on prostate cancer, global prostate cancer. But we highlighted MRI as being a key thing in first world countries to try and reduce overdiagnosis and improve detection of clinically significant cancer. So it's one of the strong call-outs. There's lots of other things in prostate cancer globally, especially in low and middle income countries, but certainly in developed countries, governments should prioritize funding. And I think, there've been many other good papers, but the PRECISION paper, for those of you listening out there, is the key one. So if you go back and listen to the summary Elena gave you, which is the best I've ever heard of the PRECISION trial, you should have done the discussion. Then hopefully this has been helpful. Yeah.
Very well done, Elena. All right, shall we move on?
Moving on to bladder cancer.
To bladder cancer. We've not done bladder cancer before on the Journal Club. And so, Carlos, a great study that you've picked today. So the background to this is that our standard of care when it comes to bladder or diagnosis of bladder cancer is TURBT, and the standard resection is this piecemeal resection of the bladder tumor. We all know that we want to aim to sample the muscle underneath, and we sort of try and get there. And most of the time, we end up doing a re-resection for those who have high-risk features or CIS. We go back and have another look and do another resection. But this is a new concept of en-bloc resection of these bladder tumors. So tell us firstly, the EB-StaR, what does it stand for?
It stands for a nuclear resection, en-bloc, en-bloc versus a standard resection of bladder tumor. Okay. That's EB-StaR trial. So as you previously said, it's really challenging how we regularly treat these small bladder tumors, and it's very hard to change practice from coming from something that is very easy and we're very used to do every time, like the TURBT.
Go for it.
Non-muscle invasive bladder cancer represents about 75% of all newly diagnosed bladder cancers. And despite better scopes, despite having good technologies, recurrence rate remains high, between 15 to 60% of recurrences happening at 1 year. Standard TURBT breaches all fundamental oncological principles. We cut directly into the tumor multiple times, fragmenting it and releasing viable cells into the bladder, potentially causing seeding and losing the ability to assess the true surgical margins. However, despite this theoretically advantage, until this trial, there was no level 1 evidence proving the clinical benefits of doing an en-bloc resection. The EB-StaR trial, en-bloc versus standard resection, is a multi-center phase 3 randomized trial conducted across 13 hospitals in Hong Kong from 2017 to 2020. They enrolled 350 patients with bladder tumors less than 3 centimeters. Patients were randomized 1-on-1 to en-bloc resection or standard resection, both using bipolar energy under white light cystoscopy. 276 patients had confirmed non-muscle invasive bladder cancer, and they were included into the final analysis. Surgeons were not blinded, but patients and outcome assessors were. The primary endpoint was 1 year recurrence rate, and secondary endpoints included progression, detrusor muscle sampling, operative time, complications, and residual disease at second look TURBT. Baseline characteristics were similar in both groups, median age of 70, most of them had a TA disease, en bloc resection was successfully achieved in 88% of the cases. At 1 year, recurrence rate was 29% for en bloc resection versus 38% for a standard resection, reaching a statistically significant difference. The benefit was most evident in single tumors, measured from 1 to 3 centimeters in size, TA stage, and intermediate risk non-muscle invasive bladder cancer. Progression to muscle invasive disease occurred in none of the patients on the en bloc group, and it occurred in 2.6% of the patients on the standard resection group. However, they did not reach significant statistical significance. Operative time was 6 minutes longer in the en bloc arm. All other perioperative outcomes were comparable. Among 128 patients who underwent en bloc resection, 82% of them were able to achieve clear resection margins. And very importantly, none of the patients with negative surgical resection margins had residual disease upon the second look to RBT, suggesting that perhaps these patients could avoid a re-TURBT. This is the first adequately powered multicenter phase 3 trial showing that en bloc resection truly reduces recurrence. A few strengths that stand out of this trial are that it was adequately powered to detect a meaningful clinical difference. The trial had a blinded outcome assessment, reducing bias. It had a multi-center design, and the high technical success rate of 88% shows real-world feasibility. However, there are some limitations. Only 1 year follow-up, so we cannot yet comment on long-term recurrence or progression rates. Hong Kong practice is to guide BCG and second look to RBT based on shared decision between urologist and patient, resulting in a lower use of BCG and second look to RBT. This could result in some understaging and particularly in T1 disease. No central pathology review, which there could be inter-observer variability in the histology assessment and reporting. And unfortunately, the study was underpowered for progression, which was one of the secondary endpoints. To conclude, EB-StaR trial provides level 1 evidence that en bloc resection reduces recurrence in non-muscle invasive bladder cancer with tumors less than 3 centimeters without added risk, a potential paradigm shift in bladder cancer surgery. It shows that en bloc resection not only makes oncologic sense, but also delivers measurable benefit, reducing recurrence without increasing complications. It is safe, it is feasible, and it's only 6 minutes longer. It is still yet to see if en bloc resection can also reduce disease progression and if results can be replicated in more larger tumors.
Very nice, Carlos. Great summary. Yeah, absolutely.
Very good.
Yep. And big congratulations to Jeremy Teo and his entire team. He presented this at the AUA in 2023 initially, and it was subsequently published in European Urology in August 2024. So I'm always really impressed when these surgical randomized controlled trials are run, and this was a big one. And we've recognised for a long time that the adequacy with which you do a TURBT really makes a difference in how someone is diagnosed and subsequently treated appropriately, because it really contributes to very accurate staging of these patients. So there are some obvious advantages of an en bloc resection over a standard TURBTs, and there you get the specimen out in one, you get a nice even sampling of the muscle layer, you don't spread little bits of tumor around that you hope you'll get out with your irrigation at the end. You leave a nice little base. Obviously, the study is really limited to smaller tumours. I mean, we've all been there, those horrible big tumours that, it's hard to see where it starts and where it finishes. And this is probably not the appropriate kind of technique yet. But certainly we can see the value of it. What do you think?
And it totally makes sense. I mean, maybe we could reduce the number of patients in which we need to use mitomycin perioperatively to reduce this seeding.
Yep.
Which, if you think it through, is the same type of patients who got the benefit of the mitomycin, the ones that got the benefit of the en bloc. This is low grade TA tumors, and they're the ones that benefit the most. So yeah, I think.
And we did talk about this. Is there a learning curve with doing this procedure? Is it something that's going to take a lot longer? But in the study, I mean, 6 minutes more, it's not too bad.
And it was a multi-center. There were different surgeons.
Lots of surgeons, yeah.
So I think they were trained in porcine models to do en bloc resection. But it's it's technically feasible in small tumors if it can replicate into laser maybe, using laser instead of the bipolar. Maybe some other urologists will feel more comfortable doing it with laser now with the popular HOLEP.
But when Jeremy Teo came on the podcast with us, Declan, when we published our show notes, we actually had a link to a YouTube video.
And we'll play a bit of it over this YouTube video as well if you want to look at it.
And our team did a couple of cases soon after that.
Now, because this is what I want to talk to you about. So Carlos has given this most compelling overview of this simple adjustment to our technique. There isn't even any special equipment, is there? It's just normal TUR equipment.
It's with the same loop.
Same loop. Okay, so there's no special equipment. It's what you do day in, day out, every day. A prospective randomized trial with a positive endpoint reduces recurrence of what is the most expensive cancer we deal with because of recurrences. That's why bladder cancer is so expensive. So here's the question, Renu. Of all the less than 3 centimeter tumors being operated on around the world tomorrow using this exact same technology, what proportion of them are being done en bloc? Do we guess?
20%.
It'll be a disappointing low number, is what I predict,
10, 15, 20%, I would say.
Yeah, so isn't
most of them in Hong Kong?
Yeah, exactly. It's true.
It's true, isn't it? And it just goes to show that it is very hard to change practice. Especially in surgery.
Yeah.
We had that great discussion with Sia Dineshwan about the extent of lymph node dissection. He still has to get his fellows to say stop, do not go further, because we're so used to a certain way of doing things. But I think there's a great case to be made for this. And I'm looking forward to the day when we'll have better robotics that will be able to go into the bladder. We can use 2 arms to kind of really pick these tumors off the muscle of the bladder, and then we may be able to branch out into bigger, more complex tumors.
I think we should start with the freaking small tumors, though. So now that I'm back at Peter Mac, as Carlos has reminded you, the old dog is back in the building from tomorrow morning, and I know I literally only do prostate cancer, but I'm going to be marching up and down the corridor looking into every operating theatre I can find, looking for bladder tumors.
If you see bits of tumour flying around.
Exactly. How big is that bladder tumour, Carlos or Owen? The fellows are doing the bladder tumours. Oh, I'm looking forward to seeing you do an en bloc resection of this. And when they look at you, I say, well, haven't you, read the, EB-StaR trial, But I think all kidding aside, it can be frustrating in surgical trials where someone goes to the bother of doing a prospective randomized trial. Beautiful, simple design, just an adjustment of an existing technique with the same technology, nothing expensive. Yet it doesn't change practice when this one should change practice. Oh, maybe I'm wrong. Maybe there's people out there screaming, "Oh, we've been doing it all en bloc," and get in touch, please. Give us a shout out if so. But I suspect it'll be a disappointingly low number around the place.
Do you have any experience with it over there, Elena?
We've tried to establish it, and trainees are taught that if you look into the bladder and you see this one tumor, which is 2 centimeters on the lateral bladder wall, then try to do it en bloc. And we've tried to establish that. It works quite well.
Okay, maybe I'm wrong. Although I get the impression maybe still a lot of them are done like we would do here,
Hence the try to establish.
She's very good. Yes,
No, it's reassuring to hear. And while you're finishing up your training, Carlos, is this something you think you'll you'll take up into the future and when you go back home and start your practice?
Yeah. Personally, I've done a couple, but it's hard because you have to pick the right patients. Some patients are just very hard to do en bloc or impossible.
Yeah, and then it's not the right thing. Yeah.
So,
and the trial built that in. I can't remember. There was a bailout rate where it was not possible to do the en bloc, but it was like surprising. It was a lowish number.
Yeah, I think about 85%. Successfully.
The successful rate was 82%.
Yeah.
Which is pretty good. Yeah.
So, Renu, what's the message for trainees out there listening to this compelling argument? They're wandering to their hospital tomorrow. If you're in a hospital that doesn't do en bloc, what's your advice to that newly informed trainee who's listened to it and downloaded the paper from the show notes?
Yeah, I think there's, like I said, it's a convincing study, and I think if you do see a small to intermediate sized tumor that you suspect to be a non-muscle invasive bladder cancer, I would say give this a go. It seems like the learning curve is small, and you have to try it and have practice with it.
And we will put a link in the show notes, not just to the actual paper, but to the original GU cast we did on it, which was with the senior author, Jeremy Teo, who goes into it in quite some detail about the technical aspects. And as I say, we did edit a video into that original podcast as well. We just put a snippet on here a minute ago. Awesome.
Well, there you go. 2 very nice studies, 2 very nice papers.
Congratulations again to our outstanding editors, Elena and Carlos. Thank you, Carlos, for all the effort you put into that.
Oh, thank you for having us here.
And it's nice that we're still striking a balance between prostate and other.
Exactly. I think that we've got that feedback from people. Thank you, Elena, for that outstanding summary.
What will they come up with next?
Yeah, I don't know. Next month. Monthly format is very popular. This GUcast Journal Club has rocketed close to the top of our popularity charts already. And we're getting that feedback. People are circulating it in their WhatsApp groups saying, oh, the GUcast covered this and that. And we have a list. We have a list of papers we want to cover. And we will go back like we did last month and do the odd historic paper from the olden days. But if you have suggestions, just get in touch on social media. Get in touch. You can track us down.
Absolutely. All right. Well, that's it from us. Thank you, Elena. Thank you, Carlos. We'll see you next time on the GUcast Journal Club.
And thanks to our supporters as ever. Our GUcast Journal Club partners are MSD, and thanks to them for their support. We'll be back real soon again. Thank you.
Bye-bye.